David, welcome to the show.
Thank you for having me.
It's great to have you. I want to jump into the meat of the discussion, if you will, from the get-go. I was struck by this article that I read that you wrote recently. I think it was published in The Hill. And the title of it, I thought was great. The title is Uninsured by Circumstance or by Choice, question mark. And you draw attention to the fact that there are many people for whom health insurance is not the panacea that many of the health policy guys, assume that it is. And you're a health policy guy, so go ahead and tell us a little bit what you're trying to talk about in this article.
Well, what I'm trying to convey is that we've become too health insurance centric in this industry, and that's not how it started. Healthcare is the relationship between doctor and patient. And the reason it's become so expensive and so inefficient is because there are too many middlemen that have come between that relationship. Insurance is one of them. Government is certainly the other. Pharmacy benefit managers, you name it. There's so many people that have injected themselves because they've seen the almighty dollar, and they're willing to create a wedge between the healer and those who are seeking to be healed.
Right. You start your article in a sort of provocative way. I'm going to read the first sentence. It starts like this. I often tell people that I'm among the statistics of the uninsured. I'm not covered under traditional health benefits, nor is my family. We use other forms of coverage that provide us with a peace of mind and access to affordable care that we desire. That must be mind-boggling for most people in DC. And so you wrote this in The Hill. Tell us a little bit about what you do and how you came to understand that. Give us a little bit about your background. We've talked about health insurance and the detriments of it over the course of many episodes here, but I like to explore the personal angle of how people get to understand this.
Well, let me tell you about my personal situation, how my family is covered, and I'm very comfortable sharing what we have and how much I pay for it. I was invited to testify before Congress, and I shared this information as well and told them that I also am uninsured statistically. So, and I just like to say that because I want them to know that there are other options, there are other forms of coverage that are not necessarily insurance. As I said, the most important aspect of healthcare is that relationship with doctors. So for that reason, I have a direct primary care physician for myself and for my whole family. And what I do in addition to that, because most of our needs are cared for at that point. In addition to that, we have coverage that is essentially catastrophic, but it's a medical cost sharing, very similar to the Christian sharing ministries. And I have a $1,500 deductible should I need to be hospitalized or need surgery or if there's cancer, God forbid. That's it. And I pay a premium on a monthly basis for all four members of my family, my wife and two children, about $474 a month.
Right. That's terrific. So we have the same thing. We had on the show, and I'll put a link in the show notes to that episode. We had one of the founders of a cost sharing ministry on to explain a little bit how that works. But it's a pool of people who trust one another and get together and put together a little bit of money every month in a pool that covers people's expenses, medical expenses during that period of time. And it's not health insurance because there's no contractual entitlement that you'll get anything that you want covered and so forth. I mean, there are some stipulation, but the idea is that everybody's going to be responsible and really try to ration their own care. But if they have a need, then there's a community of people who will step in and
if I may there, people will always say, well, David, there's no guarantee of payment. It's not insurance. It's unsafe. And what I'll tell them is, how often does your insurance company deny the hospital or the physician? And in fact, if you look at the Kaiser Family Foundation, indicated on a national basis the average percentage of denials of claims in the ACA, in the exchange, was about a quarter of all claims, 25%. And in Texas alone, it was closer to 30.
Right. Yeah, it's
So
amazing.
where's the guarantee there?
Correct. There's no guarantee. And then there's another, there's an attitude that when I tell people that that's what I have, or I mention this, you know, the people who are, you know, skeptical of this or so enamored with government-sponsored health insurance and so forth, they will, they almost make a slur that they assume that they say, well, if you get sick, you know that, you know, the government will pick up the tab, you know, that sort of thing. You know, it's sort of an assumption that at the end of the day, you're gonna be a leech on the system, right? When in fact, you're doing everything you can to not cost anything to the community and to be as responsible as possible.
That's right. Well,
so,
you know,
it's right.
Argument of a single payer government sponsored insurance. People will say, well, everybody will have access. Absolutely, yes. But you might not live long enough to get to the access because of the rationing of care and the limitation of the supply of physicians and facilities. When it becomes free,
right,
then rationing is an inevitability.
Right. So you're trying to spread the gospel, so to speak, to tell people that, you know, health insurance, or, you know, there's a conflation, and you talked about that in your testimony to Congress, that there's a conflation between healthcare and health insurance, and people will use the term interchangeably. They'll say, "Oh, I've lost my healthcare," when in fact, you know, they may have lost, a sham of a health insurance policy.
Yeah.
What is your role? You're part of a public policy foundation, and
I'm the national director for an initiative called Right on Healthcare with the Texas Public Policy Foundation. That's the largest center-right think tank outside of Washington, D.C. And although it's a Texas-based think tank, I do work with lawmakers in Texas, but I work in Washington, D.C. quite a bit as well.
Okay, so you're not focused on state policy only, or you might be, but you're
no. It's national, state of Texas, and I also assist with a few other states.
Okay, and what's the mission here for organizations like you? It's really, is it to change minds, of lawmakers, to change minds, you know, the public's minds, or how does that proceed?
Yes. Yes. Our job is to develop research so that we can educate and influence lawmakers and the general public.
Okay, tell us how that happens on the Hill. You go to Washington D.C. You press the flesh with the senators, and you tell them, you give them an elevator pitch, and they're convinced.
You know, it takes some time for them to be able to trust you because they hear so many things from so many people. And it's a challenge, and really it depends on what part of the country they're from and who their constituents are. Because if they have a GPO or a PBM in their district, you're not going to be able to really have a discussion with them about eliminating a safe harbor or mitigating the expense of medications and things like that. But for the most part, I think that they appreciate my perspective because I come from the healthcare industry. I'm not a policy person. It's not the world that I've grown up in. I'm rather new to it, to be quite honest. I miss being in the hospital, honestly, and I miss being around physicians and patients. But I'm thankful to be where I am because I can be more a part of the solution than I was back in the industry that I love.
Tell us about your background. What did you do before you took on this position?
I was a hospital executive and CEO for a number of hospitals. The last 7 years of my career, I was a turnaround specialist. I would go to hospitals that were financially distressed and on the verge of bankruptcy, and we'd get them healthy again.
Okay. But to do that, you do that by improving health insurance payer mix and that sort of thing, or what's the secret sauce?
No, I didn't focus on insurance. My first priority, and people would typically don't believe me when I say this, but my first priority was patient safety. Because if you don't have a safe hospital, you're not going to get the physicians to come so that they can bring their patients, and so on and so forth. So in order to be profitable, you need to have a safe environment. The second thing that I did was I partnered with physicians. I was taught very early on. One of my mentors was a urologist when I was a young administrator. And he said, David, nothing happens in a hospital except for at the tip of a doctor's pen. As an administrator, I can't admit patients. All I can do is build buildings, buy equipment, and hire staff to take care or to support the physicians and to take care of the patients. When you understand the role in its proper place, then it's much easier. I think most of my ilk, you may believe it, you may not, they don't really tend to like doctors, hospital administrators.
Yeah, there's clearly not a love relationship between between both groups, doctors and hospital administrators. Keep talking, because that's an interesting perspective. So you're trying to make the hospital safer, which I would imagine would be appreciated by the physicians in general. Is that and then that would translate, you think, into a public perception that the hospital was getting better and cleaning up its
Well, that's only a piece of it.
Okay.
So you want to take care of the safety from an environmental perspective. You want to have good staff. The way that you're going to make money in a hospital is that you're going to have surgeries. You're going to have your surgical procedures. And one of the most important specialties you can have in your facility is your anesthesia. Having a professional there that other doctors trust to take care of their patients, and that there's not that concern when they put their patients under the knife. And then going to the doctors and saying, look, when do you want to have OR time? And what if I can get you to have 6 procedures instead of 3, or if it's ophthalmology, if you want to have 15 instead of 12. That translates into more money for them, and I understand the economics of that. So we could turn it. Well, we were really. It was a priority for me to make sure that rooms were turned around, and that we were focused on meeting the needs of the physician. It wasn't necessarily meeting the needs of the hospital. We were there to serve the people that needed to be taken care of. And who were they taking care of? They were taken care of by the physicians.
Our perception, and we're not in the business of running, so there's a lot of, there may be a lot of misperceptions about how hospitals are run, whether they have a very cushy bottom line or not, because we don't know, we're in the dark. Mm-hmm. The importance of having a lot of nice, a lot of private, patients with a lot of private insurance, as opposed to relying on Medicare, Medicaid. Were you in situations where at the end of the day, you were so constrained by the payer mix, by the demographics, by the regulatory impositions, by the fact that you couldn't capture revenue because the electronic health record perhaps was not up to snuff, and all that stuff, that it was just it was terminally distressed, and then the option is to merge with a bigger system and bigger means, because we tend to see that quite a bit, right? I mean, hospitals are distressed, and then they get gobbled up by the bigger fishes.
Yeah. Well, my job wasn't to merge them with a bigger fish. That's lazy from my perspective. I was hired to do a job, and my job was to get the hospital profitable. My goal was to make it profitable on Medicare and Medicaid. And if we could do that, the rest of the private insurance was gravy. And we were able to do that. I had a pretty good success rate.
Okay.
And I'm very proud of what I was able to achieve, because again, I partnered with the doctors, and I considered them to be friends. And that's where your business comes from. But as far as trying to recall the rest of your question now.
No, I mean, I'm saying that, what did you think of the story that developed in Philadelphia in Anisha's neck of the woods about this hospital, Hahnemann?
Mm-hmm.
And is it a matter, I mean, do you think that it's, these can be mismanaged and it's always possible to salvage, even at Medicare, Medicaid rates?
Yes.
To salvage a hospital?
Oh, without question. I think many hospitals suffer from administrative bloat. And it's important for a lot of these guys to have nice offices and lots of staff that support them, but it's absolutely not necessary. One thing that was a trademark of how I operated was I subscribed to a management principle that I learned in graduate school. It was referred to as MBWA, management by walking around.
Management by what? I'm sorry.
Management by walking around.
Okay, right.
So I didn't spend a lot of time in an office. I spent my time with the staff. I spent my time in the OR. I would scrub up and stand next to my surgeons, and I would go into the ER and I would go into the patient floors and I'd hold patients' hands. That's what you need to do as an administrator, because how else will you know what the needs of your patients are, what the needs of your customers, who from my perspective, that was my doctors. How would you know what their needs are? And so I wasn't going to rely on my direct reports, although I took their recommendations, but people tend to embellish or hoard, and I needed to see things with my own eyes.
Right. And what, so you go from hospital administration to health policy. You felt that was a necessary next step. I mean, why did you see clouds on the horizon that, there was something that compelled you to go into the health policy front?
There was a step before that was in the middle.
All right.
I was very frustrated by hearing our politicians say, you're going to lose your health care, or you're going to, this is going to happen to healthcare, when clearly they weren't talking about healthcare. They were talking about health insurance. And the amount of regulations in our industry is just astronomical. It actually exceeds that of the IRS tax code. So out of frustration, I ran for U.S. Congress in Houston.
Oh, okay.
And I thankfully did not get past the primary. And I was actually offered a position. I had the opportunity to go back into the hospitals, which, again, I love the hospitals. I'm one of those weird people that even likes the smell. But I had spent the prior year telling people how healthcare was just so fundamentally broken. Mm-hmm. And there was a lot of internal conflict for me to be able to go back and be a part of what I considered to be a problem. And so I didn't have any options or solutions. I just knew that I had a message and I wanted to continue sharing it. So with my very understanding wife, allowed me to continue campaigning for healthcare reform. And I did that on my own dime for the remainder of the year. During that time, I became a healthcare advisor for a few congressmen, a few state representatives in Texas. And it was a good situation, but word got around to my current employer, and they liked what I was doing, and they brought me on board. What
was your intellectual journey in terms of how you understood? Because there are many people who are in healthcare who evidently don't see it the way you and I see it necessarily, right? I mean, there are people who are just veterans of the healthcare system, right, who still, hope for, the big, solution to come from Washington, or, the big subsidies and whatnot, and who are resigned to having everything handed down to them. What was it for you that made you see things in a different way?
It might be that, for me, it's always been about patient care, as I said before. And when you have your focus on the patient, you start to recognize and realize that all of these other things they're superfluous. There is a little bit of value, but not the kind of value that they put on it. So my experience working, before being on the administrative side, I worked my way through college in an ER as an orderly when that was such a job. But it's just been very frustrating. I've also done consulting work with other countries. I've been to Antigua. I've been to done some work in Canada, and I've done some mission work in Costa Rica. Mm-hmm. And the thing that I saw consistently is that the more that government is in control, the less people have. And I'll give you an example of what happened to me in Costa Rica. The pastor's wife with whom we were staying was just diagnosed with cervical cancer. And she had gone in for another visit. She wasn't feeling well. And it was an advanced cancer. And they said, yes, we're going to schedule you for surgery, but we need to have an ultrasound first. And they said, okay, well, when are we going to schedule the ultrasound? They said, we're going to have it in 12 months. Well, when would we have the surgery after the ultrasound? Probably another 12 months. Now, make no mistake, she had access. But was she going to live long enough to get to it? That's the future we face in this country.
Right.
Do we want universal access and Medicare for all and all these free services from the government? You may not get it when you need it.
What's the broad strategy here for you? I mean, if you're looking at, if you take the long view, the next 10, 15, 20 years, I mean, the overall message is you want less government, less third-party intrusion, and so forth. But do you see it as a gradual step-by-step, and this is the first thing that needs to happen, and then the next thing, and then the next thing? And do you have a sort of a vision or a strategy in mind?
Maybe it's just my makeup, but I don't. Yes, I have a long-term vision, but I don't operate that way because having been in turnaround situations, I have weeks and months. And when we're talking about where we are today as a country with healthcare, we have months and a few years. So I have a great sense of urgency to change as many minds and to educate as many people as I possibly can, and to create a coalition that will spread that same message so that we can magnify the voice of both patient and doctor.
Right. But still, I mean, what would be something, in your wish list, in your realistic wish list? You want more people to join cost-sharing ministries and sort of disinvest themselves from the insurance system, or do you want more short-term health insurance, which the Trump administration seems to be promoting, and it's a relative benefit compared to the prior situation and that sort of thing?
Yeah. I apologize. That's a good question. What I want is this. I want as many choices as possible so that people can have freedom to choose. That's essentially it. Because on one side of the aisle, they want to have a system, and the ACA is one of them, where they've limited choice to just being insurance. And on the conservative side, it's not much different, to be quite honest, because one thing that I'm constantly going up against is the solution that they're bringing to the table is, again, insurance-centric. We need to have as many options as we possibly can. Cost-sharing ministries are not for everybody. Medical cost-sharing is not for everybody. Short-term plans, I'm not even a real big fan of those. I think it's a good option for a lot of people. And should it be in place? Absolutely. Mm-hmm. The association health plans, great innovation. We need to bring back catastrophic plans. I'm not opposed to insurance. I just think we use it wrong.
Right. And you see, so tell me your experience has been, how long have you been with this, the Texas Public Policy Institute?
Since January 2nd.
Okay. So about a year.
Almost, yeah.
Almost a year. We've had sort of, it hasn't been really focused, but we've had some updates on what's happened with the current administration. And in generally, we've seen that it's been positive. They've been, granted this primarily at the level of executive orders, and so it may not be permanent and that sort of thing. But certainly there have been motions that you've mentioned now of trying to give people more choice, and also promotion of direct primary care, that sort of thing, which is, all very positive. At the same time, there's potentially a fiscal crisis looming. There's a fear that you actually need to reduce choice because you're going to have the other side who's going to be very, very strongly trying to push for less choice because they want healthy bodies to sort of subsidize, the big machine, the big single payer system. There's going to be a very strong push. And where do you think the vulnerability of the single payer camp is, so that people will move in the direction that you want to move?
Well, let me say this first. With the exception of Bernie Sanders, I don't think any of them believe that a Medicare for all or a single payer system is a viable option at this time. I think it is as much a campaign position as repeal and replace was for the Republicans.
Okay.
It's a talking point to rally their base. I do believe that the majority of them will go back and try to strengthen the ACA. I believe it's very interesting that all of them have taken the position of supporting the Medicare for All plan. From my perspective, that means they have forsaken the ACA. But on the other side of their mouth, they're saying, no, we need to strengthen the ACA. They're mutually exclusive. You can't do both.
Right. So what's happened to the ACA? Because we don't have sort of real-time data on what's happened since Trump has rescinded the penalty and so forth. What are the numbers? Where do you see? Do you have your pulse on what the trends are?
Well, a number of the insurance CEOs have said that it's finally stabilized. Interestingly enough, President Trump has done some good things for the ACA, even though he's supporting the lawsuit that seeks to strike it down. There's more competition. You see the premiums going down on the ACA exchanges in the states where short-term limited duration plans are selling, because the competition has pushed down, has downward pressure on the premiums. Imagine that.
Okay. So it's not necessarily the death spiral scenario that's taking place. The health plan are actually doing okay, even with lower premiums.
That's correct. Yeah.
Right.
Yeah. And we can go back to the very beginning of what we discussed. Why have people left the exchanges? Why are people leaving Medicaid? Because that's exactly what's happening, especially in California, which is a Medicaid expansion state. There are more of those that are uninsured that are Medicaid eligible in California. And we have, of the uninsureds in Texas, for instance, 12% are Medicaid eligible. So they've chosen, for whatever reason, to not be on Medicaid, even though they could be.
Right. I mean, because who wants to have just a little plastic card that nobody accepts or gives you access to very little?
That's correct.
Right. Although I suppose you get access to the hospital if you in the case of an emergency. So that's Anish. Any thought on
There you are.
You're muted. You want to unmute yourself?
No.
Okay.
Yeah. No. It's been. Sorry. Go ahead. You were saying something.
It froze a little bit. I'm sorry.
Yeah. No. It's been interesting to see it. Do you feel? Part of the issue here is that I found. I don't know if you're frustrated by this as well, David. Is that you kind of have, the foxes guarding the hen house in terms of, say, CMS and this large third-party payment system that I think many of us would like to see shrunk at the very least. And, it seems really, really hard for the trajectory of that to change regardless of what administration, is in charge. So Seema Verma, seems to be continuing to travel down a path of, value-based care and pay for performance. The initiative recently with regarding dialysis, etc. Again, it's not unfortunately getting out of the way of how one reimburses care. It's just finding different ways to do it, which kind of seems to, I don't know. It seems like I find little hope sometimes when I look up and I see, regardless of what, who's in charge, we're still getting basically the same message being passed down. Is that your impression as well?
Yes and no. So the way that I would respond to that, and I appreciate the sentiment, I really do. The way I would respond to that is by saying this: I think our current healthcare system is irreparable. That doesn't mean I'm without hope. I believe that we can create a parallel system that runs alongside of it, and we need to support those doctors and those types of facilities that have taken risks and have done things differently, the way they think that it should be done, in the best interest of their patient, offering affordable care. The more we can see these types of models proliferate, the more pressure it'll put on the existing establishment. And that's what I would like to see more of. I'd also like to tell a quick story about CMS. We were talking about direct care. I don't know if you remember, they had an initiative supposedly to support direct primary care. But it really wasn't, because what they wanted to do is they wanted to pay the membership fee directly to the doctor in exchange for the claims and the records being sent from the physicians. Well, you're not going to get any DPC doctors doing that because they don't function that way. So my conversation with them when I was in DC was, give the money to the patient, give them a card, load it with enough money to pay for a monthly membership, and have it sweep. That's fine. And there was a lot of back and forth and push and pull, and they didn't really like that idea. And out of frustration, they said, David, where are we going to get the data? And then I understood. It's not about affordable healthcare. It's about the collection of data, and it's about the control of the data, because that can be, it's lucrative. That data is monetized by a lot of people, but just not the patients.
How does one, and again, part of the issue is that, we seem to have trouble unifying, and part of the trouble unifying relates to the fact that we have a lot of different competing interests, and there's certainly a number of physicians and physician groups that may not be the greatest actors in this space, right? So we've been talking a lot about surprise billing recently, and I mean, there's no doubt that folks do use surprise billing and balance billing to take profit out of the system. What do you think the best way of advocating, as somebody who's got a lot of experience in this stuff, how do we best advocate in a way that doesn't position physicians as kind of greedy rent seekers, greedy profit seekers that are doing this at the expensive patients? So
how do we rebrand?
Yeah, or how do we given all the bad players, because the issue is, of course, is that if we any moves that we make will result in some winners and losers. Some of those losers will be physicians, for instance, that are currently profiting based off of the current system. So how does one navigate this path? Not that profit is bad. Sorry,
yeah,
but I'm talking about. I just mean folks that are rent seekers. So meaning there's profit that's being gained without necessarily giving real value.
Right.
And so it seems one of the hard parts of unifying physicians is that we've created this beast where there's a significant portion of folks that do generate a lot of revenue without value, we've created a lot of rent seekers in the system. How do we exactly how do we navigate a path that that kind of gets physicians unified in a way that's a positive to...
Well, I think I need to talk to you all about the other thing that I'm currently doing. I'm also one of the founders of an organization called Free to Care. Free to Care is a patient advocacy and physician advocacy coalition. It's made up of member organizations. We are about to have our 1-year anniversary on November 1st. And we also have a conference at that time. The coalition now, in under a year, we have 22 member organizations, 2.3 million individuals that are represented by those organizations, and 35,000 practicing physicians. And I think the success behind having, being able to unite, and mind you, it's a bipartisan group. We have liberal Democrats and conservative Republicans and everybody in between. Well, how would you do that? We have very specific platform issues, and we're very disciplined about sticking with those issues. We don't talk about things outside of them, because when they join, they've joined in support of those principles. So that's how we've done a good job, and we've been able to get the ear of some senators and the White House. And here recently, in response to the president's executive order for Medicare, there was a petition that was put out, and after only 4 days, there were 22,000 signatures by physicians in support of the president, in support of the executive order, with the exception of one element of that executive order, and that was for the reimbursement parity between physicians and extenders. But we've been able to do it, and it's growing by leaps and bounds. And I'm proud to be a part of something that is so remarkable.
Wonderful. That's great.
That's great. David, I want to go back a little bit to what we were talking about earlier about the ACA. Again, just because you're sort of an insider, or as much of an insider as we've had.
Oh man, don't say that.
On the show, but you were saying, because at the same, on the one hand, you said that premiums have come down. On the other hand, you're thinking that the system is unsustainable and it's or irreparable. Did the premiums actually go down, or did they increase less than expected? Because frequently in healthcare, when you hear things that are coming down, it's not that they're actually coming down; is that they're not increasing as much as people had projected. And that's do you know exactly that?
I hate the term of slowed growth. I think that's ridiculous. No, they've actually decreased, especially in those states where they have the short-term plans and the association health plans, because of the competition.
Okay.
Drives that down. But yes, it's unsustainable, because why has there been such a departure from the ACA by many people who are eligible for the tax credits? Now think about that. They're getting insurance where they have to pay no part of the premium, yet they're not taking part in that. That doesn't make any sense, right? Yeah, it does, because you know what? They have a deductible. It's around $5,000. So even though it's, and again, I'm using air quotes, even though it's free, they're functionally uninsured, because more than 60% of people in this country don't have $1,000 in their savings account.
Right.
So what are they going to do with a $5,000 deductible? They're going to go to the ER. And that's
right.
exactly what we're seeing.
Okay. But if the premiums have come down, the health insurance company, there's no imminent threat to the, it seems, to the major health insurance players. They're still sort of flush with cash and doing okay for foreseeable future, or despite losing, people who, who choose not to have insurance.
Look, if you just go back and look at the stocks of the major health insurers from 2010 to current day.
Right.
The ACA was a gift.
Yeah, of course.
Special interest. They made money hand over fist. Pharmacy benefit managers, GPOs, hospitals, insurance companies, everybody except for the patient and the doctor.
Right. Yeah. So, so they're doing well. They're going to stick around for at least, several more years. The prediction might be that the status quo will continue for a while. The quality of the care will continue to get worse, because the experience from the patient standpoint is getting worse, because the care is more fragmented. You have these narrow networks. You have these doctors that are stuck to their electronic health records, that don't talk to each other, and the doctors have no time to talk to the patients or to their colleagues and so forth. So, right, the the healthcare experience is getting worse, there's the possibility that, in the meantime, the direct care, um, uh, field is growing as fast as it can. Certainly, direct primary care is doing well, and so in that sense, I'm with you that it's sort of hopeful. I mean, that we may want to, because we don't want a total catastrophe. If the system collapses completely, then there's a real danger that you could have a complete takeover of healthcare by the government. On the other hand, if there's a status quo, but it's sort of the kind of really terrible care that people are getting, that incentivizes folks individually to go and seek out free market solutions.
Right.
That would be really, I mean, what we can hope for.
Yes, the employers need to play a bigger part. Patients need to do a better job of doing some.
Right.
And
the employers, as you mentioned, especially the self-funded employers. We had Jay Campton on the show a couple of episodes back, and that could be a very, very interesting development. Do you do anything on that front yourself in your current position?
Well, I educate the employers, and we have several restaurants, very famous ones. One in particular by the name of Rudy's, but it was a family of restaurants. And the gentleman, I heard him testify before the state legislature in Texas, and I loved everything he had to say. He said, in the history of my company, I've always offered health insurance because I felt like it was the right thing to do. But when the cost of insurance outpaced the cost of my material that I sold in my core business, I knew I had to stop. I knew something had to change. But he didn't stop. What he did was he tried something new. He tried something innovative, and he employed direct primary care. He works with, you're familiar with the Surgery Center of Oklahoma. We have a very similar organization in Austin called the Texas Free Market Surgery Center. And he works with that organization as well. So if the direct primary care says, yes, he's eligible for surgery, this is something that they need, if the patient agrees to go to the surgery center, he'll pay for it out of pocket.
Right. That's terrific. That's really, I think, the most hopeful, very, very hopeful trends that will happen. Again, provided Washington doesn't get into a mad rampage of regulation and takeover of the healthcare business. And what you're saying seems like, again, the fact that the ACA is not catastrophically crumbling or threatened, in a way, is a positive, because it's going to dampen the enthusiasm for a real radical Medicare for all solution.
Well, that doesn't mean it's. I still believe that it's inappropriate for a number of other reasons. It's unconstitutional, being the biggest. The second, it limits choice in other areas.
Sure.
We don't have catastrophic insurance because it's a restriction by the ACA. Something else that I think is a significant problem with the ACA is that it has a permanent moratorium on the ability of physicians to build hospitals, which is restricting the competition against these big mega.
Correct. That's terrible. I think it predates, or maybe the ACA solidified it, but it's a really there is the hospital lobby that is preventing, that was behind that measure, if I recall correctly.
I have a pretty good hunch that's the case.
Right. Yeah. But you're right. We need small private hospitals that may, begin with a more limited offering of services, and then, over time grow to complement the outpatient surgery centers,
right?
And do so. And do you see at the state level that? Do you think it's a sort of an economic problem that right now? Because, correct me if I'm wrong, but legally somebody could open a private hospital. The only problem is that they wouldn't be able to build Medicare or any of the ACA insurance in the traditional way.
Well, and they couldn't admit their own patient. You can't benefit from those payors for patients that you admit as a physician.
Right, but if patient paid privately, there are some conditions that may demand, 2 or 3 days of hospital stay that don't require, that could potentially be payable on a cash basis.
Yeah, if it was
Is
all
what
cash, there wouldn't
right,
be. However, I believe that at the state level, which is where the license is issued,
right,
that may be an obstacle, but I just don't know the answer to that. But that's something.
correct, right. Well, very good. Anish, anything else you'd like to? This is I didn't know whether the conversation would leave me hopeful or pessimistic, but I think what you're saying is continues to give me a lot of hope.
Good.
That minds are changing, things are moving in the right direction. As I said, hopefully there's not going to be an implosion, a catastrophic implosion that is always a danger, and we'll continue to plug along and change minds. And it's good to have you on in Washington, sort of telling people that there's another way of looking at things, and that health insurance is not healthcare, and it's a very dangerous conflation of two things.
Without question. And if there's one thing that I can say to your audience is, please be involved. Call your representatives, call your senators, call your state lawmakers. They want to hear from you. They don't understand healthcare, and they may not say that out loud in front of a camera, but they may say it to you. But they'll ask for your advice. They'll ask for your situation, for your stories, because it helps them understand what they don't now, and they may trust you more than the lobbyists coming into their office, because they're there because they're paid to be there. You're having a conversation with them because they know that you live there every day and you care about what you're doing and you care about your patients. So I would beseech your listeners to please. You may think that it's not working, that it is ineffective, but if it's effective once, then it's worth it.
Right. I think that's a very good point. I tend not to do that by virtue of where I live. I mean, my representative is Nancy Pelosi. She might, she might. I don't know to what extent she'll listen to me, but I think in general, as a principle, I think you're correct, and my mind has changed on that. I mean, I used to think that it was completely hopeless, that all we had to do was completely bypass the system and whatnot. But I think the last 18 to 24 months have demonstrated that actually certain good things can happen. I mean, there is a role for the legislatures to facilitate more options, and they can do that, and they need to hear that message. And so I think you're absolutely right.
Yeah,
you're absolutely right. David, where can people follow you? You're right. I think you have a lot of great articles on the website of your organization. You want to give us a couple of links? I'll put them on the show notes. Your Twitter handle?
Twitter handle is David Balot, HC for healthcare. I'm pretty active on Twitter. You can go to the foundation's website. That's texaspolicy.com. And if you go to the issues tab, you can click on the expert field and look for my name, and all of my articles will pop up. And then also you can go to the Free to Care website, which is free2care.org. And that'll have a listing of all of the member organizations that are physician and patient advocacy groups.
Sounds great. Thank you so much for joining us, David.
Oh, I had a great time. Thank you for having me.
Thanks again.
Take care.